A hernia is where organs from one section of the body prolapse or protrude into another section. In abdominal wall hernias, usually this means there's a weakness of the abdominal wall and the contents of the abdominal cavity prolapse either externally or they prolapse into another section of the body. The most common types of hernias are inguinal hernias and umbilical hernias. So with an umbilical hernia, near the belly button, a small bulge develops through a weak point in the abdominal wall, and then the abdominal contents can prolapse in and out. These can be incredibly small, a few millimeters, but they can also expand over time and be quite sizable, where significant portions of the abdominal contents are prolapsing in and out. In inguinal hernias, there's a prolapse of abdominal contents through the inguinal canal. So the inguinal canal is really interesting. If you actually look back to fetal development in, say, a male, the testes originate in the abdomen, and through that fetal development, the testes migrate down through a tunnel to eventually reside in the scrotum. That tunnel should close over. In an inguinal hernia, that tunnel starts to open up again. And if an abdominal contents prolapse in and out, we use the term an inguinal hernia. Inguinal hernias can also occur in females. It's the same inguinal tunnel. In females, the inguinal canal is the tunnel for which the ovaries are pulled down from their initial position where they reside higher up in the abdomen to eventually reside lower down in the pelvis. Femoral hernias are different but close to inguinal hernias. In femoral hernias, there's a weak point near the femoral vessels which lie in the thigh. They can still give the very similar sensation in that there's pressure or bulging near the groin, but they originate through a different defect. So as opposed to being in the inguinal tunnel, a femoral hernia arises in the femoral canal, which is the little tunnel next to the femoral vessels, which are vessels near the thigh. Unfortunately, the natural history of hernias is that they increase in size over time, or that eventually patients can develop a complication from them. So by and large, surgery is the mainstay of treatment. Some patients may trial hernia belts or conservative measures, physiotherapy, but ultimately, unless we repair the defect, there's a real risk that they can increase over time. If you look at inguinal hernias and femoral hernias, most commonly I perform a laparoscopic repair, and what that involves is a keyhole repair where I find the weakness that's at the abdominal wall and it's reinforced. With the repair, we use a lightweight, soft Prolene mesh, and what that mesh is, it's a soft scaffolding that the body fills with collagen. As the body fills that mesh with collagen, the hernia repair develops strength. Usually hernia surgery is done as day surgery, so patients have their procedure, it's under a general anaesthetic, but they're discharged after observation. With the recovery, until that collagen fills the mesh to give the hernia repair strength, we want to avoid heavy lifting, heavy exertion, and heavy activities. Avoid driving for 2 weeks, and I usually suggest that patients avoid lifting anything over 1 kilogram per week for 8 weeks. So nothing over 1 kilogram for the first week, 2 kilograms for the second week, 3 for 3 weeks, and then onwards.